So I'm Jill Buyon. I'm at NYU School of Medicine. I am the director of the Division of Rheumatology, and for several decades have led a major program in neonatal lupus and the management of pregnancies in which a mother has antibodies to SSA-RO and/or SSB-LA. So I'm here today to discuss several issues related to the management of women with anti-RO antibodies, and in particular to focus on congenital heart block as a manifestation of neonatal lupus. So we're going to just review several facts regarding the frequency, who's at risk, and we'll get into a little bit about the management and some of the controversies that have been recently raised. So I think, to start off, why is it important to be listening in? And I think the fact is that there are actually many women who have anti-RO antibodies. In fact, otherwise healthy women, this frequency can approach almost 1% of the population. So that is to say that you don't necessarily have to have an autoimmune disease to happen to have these antibodies. If these antibodies are present, the chances of having a child with a cardiac manifestation of neonatal lupus approaches about 1 to 2%. Having a higher titer of anti-RO antibodies matters, and it may well be that low titers actually do not pose a risk at all. On the flip side, if you're facing a pregnancy as a physician and an otherwise healthy woman is found to have a fetus with a bradycardia, and it turns out to be an AV nodal block, and it's in isolation, there's no structural reason, there's no obvious genetic reason or infectious, chances are greater than 85% that woman will have anti-RO antibodies. So this sort of suggests that the antibodies are necessary, but they're not sufficient. Now, if you had a previous child with heart block, your risk of having another affected child zooms up a bit to about 18% or so. But also keep in mind, if you had a previous child with rash, that risk also goes up more than just 1%, maybe to about 13%. So previously affected children will have an influence on an increased risk for that mother to have another child with neonatal lupus. So how do we approach this problem? Well, keep in mind that the cardiac manifestations do have a bit of a spectrum, and that is there could be first-degree block, second-degree block, third-degree block, and there could even be what we refer to as extranodal disease, most commonly endocardial fibroelastosis, and the extranodal disease carries significance with regard to an increase in mortality. Overall mortality, about 17.5%, but if you have extranodal disease, this mortality can go up to, unfortunately, even 30%. So our approach, we used to think that the approach was, try to find something early, and therefore it'll be most treatable. So our approaches were echocardiographic surveillance during the vulnerable period, which is clearly around 20, 21 weeks, maybe 19. So we suggested that we would monitor between 17, 18 weeks, and maybe 26, 28. We've really narrowed that time frame down kind of to 17 to even 25. Suffice it to say, there's a lot of controversy now about that, because have we really made a difference in early detection by even weekly echoes? And so unfortunately, in the last few weeks, there's been a lot of controversy in the literature that maybe we shouldn't bother doing surveillance, because what are we learning and have we really fixed anything? I very much disagree with that. I think knowledge is important. I think that knowledge is power. And in fact, there are reversal of second-degree block with aggressive anti-inflammatory therapy. And I think we should consider at least major discussions with our patients before we close the door on opportunity. Now, if in some cases we have addressed prevention, because prevention is probably, that's going to be the best strategy, and we have in a open label, non-randomized study, acknowledging the shortcomings of such a study design, demonstrated that hydroxychloroquine can reduce the risk of congenital heart block in someone who's had a previous child with heart block by about 50%. obviously, again, the shortcomings of an open label study. With regard to treatment of established, disease, we would still advocate second-degree block being treated, whereas others may not, but I think the general consensus is that would be the case. Third-degree block, much more controversial. The Canadians, for example, major work led by Edgar Yagi, suggests that all fetuses with block should be treated with anti-inflammatory approaches. In our own hands, a major study from our research registry for neonatal lupus basically showed that in isolated third-degree block, whether there was treatment with dexamethasone or not, the outcomes actually were the same, and thus we don't recommend across-the-board treatment of isolated third-degree block. So a new approach that I just want to mention is that of the home Doppler, where we are trying to utilize, leverage 3 times a day home listening and trying to see whether we can find the earliest change. I mean, imagine if you could detect a change in the heart rate or rhythm within 5 or 6 hours and get treatment to a fetus. Would that possibly and permanently reverse any injury that's going on before scar? And so I think that's where we're at right now. And any further commentary or questions, I'm happy to address.